it's a pleasure to introduce, as our guest speaker this morning, Dr. Erica Scavella. Dr. Scavella is a member of the Senior Executive Service, serves as Assistant Undersecretary for Health for Clinical Services and the Chief Medical Officer at the Department of Veterans Affairs, overseeing medical care provided to over 9 million enrolled veterans annually at over 1,700 sites of care. The Department of Veterans Affairs is the nation's largest integrated healthcare system, and don't take that lightly. That means a lot. We have a lot of bandwidth to learn, and certainly what we do, we cut quite a swath. Dr. Scavella defines VA's clinical strategy and policies in order to assure the provision of an enterprise, patient-driven, evidence-based standard of care and the reduction of unintended outcomes. She supports and drives data-driven, outcome-oriented, resource-efficient, field-based oversight and operational improvement, and enables the professional development of clinicians and leaders in order to optimize the operational strength of the system and deliver world-class health care to all veterans. Prior to this appointment, Dr. Scavella served as VA's Associate Deputy Undersecretary for Health for Oversight, Risk, and Ethics, executing the duties of the Chief Health Risk Officer, and prior to that as the Medical Inspector, conducting and overseeing over 250 clinical investigations. I hope you had hobbies and outlets, I'm just saying. Dr. Scavella earned a BA in Biology from Rutgers University and an MD from the Robert Wood Johnson Medical School, Rutgers University, formerly the University of Medicine and Dentistry, New Jersey. Most importantly, she completed a residency in internal medicine at the University of Maryland, go Terps, and is certified by the American Board of Internal Medicine. She was elected Fellow of the College of Physicians, ACP, in 2005, and Fellow of the American College of Healthcare Executives in 2012. She completed the Harvard Kennedy School Senior Executive Fellows Program in 2017, is actively engaged with the Association of American Medical Colleges on expanding and lengthening the pipeline for diversity in U.S. medicine, and serves on several boards to include the Accreditation Council for Continuing Medical Education and the National Board of Medical Examiners. I'll just say this, it's great to have someone who's walked the walk, been in our shoes, and certainly listens and comes up with reasonable solutions to satisfy all stakeholders involved. I'd like to introduce Dr. Erica Scavella. Thank you very much.
Good morning, everyone. It's so awesome to be here with you all. Dr. Latas beat me to it. I wanted to see who the veterans were in the room. Just truly want to thank you for your service. Your perspectives, having served and then now serving those who serve and are, recently deployed or just, have been in our system for years, that perspective changes everything for them. So proudly let them know that you sat where they're sitting, and that you have, many of you probably use our system as well. So let them know that, and let them know how proud you are of the system that you work in. I never thought I was going to be a leader, so I'm looking at this room, and I hope that those of you that have an interest in leading take that to heart and follow your passions. I follow my passions. I didn't have a plan in place. I did not have a blueprint to get me to this position. I just wanted to serve and make a bigger impact, and just found ways to do that, and then was fortunate to get the opportunity to serve in different positions. So I just encourage any of you who have a passion in a specific area to follow the passion, to do what you love, and that will hopefully get you to where you want to be within this amazing system. Just to tell you a little bit about myself, so I was not one of those who was able to stand up. I did not have the opportunity to serve, and I thought about it before my 40th birthday, but I had middle schoolers, and I had a husband who's also a physician. We also went to school together. And for us, for our family, I didn't think it was going to work for me to potentially be unable to control my schedule, any less than I already could as a physician. So opted not to look into what my opportunities might have been at that point. But I'm so envious of those of you who have served, because I think that gives you a unique perspective that I will unfortunately never have. I do love veterans. My grandfathers, my great uncles served, and currently I have 2 women who are cousins of mine who have served. So I see it from their perspectives. I've seen them choose VA when they can choose to go to the private sector only. So when I came into the system, I thought I was going to become that kind of physician that would come into the system and take care of patients like my family who could come to the VA if they chose to, or they could go outside the system if they chose to. So I always had those dual care patients before we had what we call community care. I always communicated with the physicians in the field who were taking care of my patients because it was more convenient for them to come and see me to get some of their care and to go to their local whomever for whatever else they want to get. So I just really am grateful for the opportunities. When I talk to groups like this, I usually want to first of all share a little bit about who I am. As I said, I had 2 middle schoolers at the time. Now I just have another student who's a third year who just started his third year rotations. And I have another son who's a year younger than him who's just graduated from college, who is just out in the workforce, not in medicine at all. As mentioned, my husband is a physician. So those kind of things are who I am, and people who know me know that about me. I bring that to the table. I bring being the granddaughter of veterans, the cousin of veterans, to the table, and the fact that the importance is truly my family, but it's also each of you in this room and encouraging you to be leaders that you want to be. One of the things I know is that you couldn't have the undersecretary here, so I always try to bring perspectives from that, just to have you know what it's like to work at this level and to know where some of the pressures are. So you see the end result of everything that's happening on the Hill. The PACT Act, which I know was a huge lift. I really want to thank Dr. Matras and his leadership in making sure that we were able to translate the legislation into what was actionable in the field. And I know that the reason why we're successful with the PACT Act and implementation is because of each and every one of you in this room. We exceeded our goals of the number of people we wanted to get screened months ago. So just major applause for everything that you've done in support of veterans. That is the biggest piece of legislation that has been passed that has impacted the ability to enroll veterans and also to bring benefits to veterans. So thank you for your role in getting those screenings done. I know it was a heavy lift. We talked about it often, about the fact that the burden of this legislation was on primary care. It is known in headquarters. It is known by the secretary. It is known by the undersecretary for health and the rest of the team. We know that primary care is the workforce that brought that forward. So I just want to thank you all for everything you've done to make that a reality. As you know, we have veterans who, for years, have been told there's no proof for what you're complaining about, or what you're concerned about, or what you're feeling. And we can't link it to anything because there's no evidence. So in partnership with our research folks, we're able to get that evidence and start doing research that's going to make those presumptive diagnoses into clear cause and effect, or at least a definite scientific belief that is more firm than it is today. So we hope to continue to increase the number of diagnoses that would help to get a veteran service-connected, which could potentially make a difference in that veteran's life, the life of their families, the life of their caregivers, and in cases of their passing, the life of their survivors. So it is impactful what you're doing. It will change those veterans' lives and the families that care for them and love them. Let me just tell you a little bit more about how things happen in headquarters. I actually met with an employee of ours this past week, and she mentioned, I never want to do what you do, which is testify before Congress. And I had that same thought. I never thought I'd actually be okay with testifying before Congress, because it's been daunting. But I get the opportunity to go up and talk about everything that we're doing in this room and across the country and across the globe, because we do have locations across this country as far away as the Philippines, as I can. We have locations that provide care. So I just want to thank you all for the work that you're doing to make an impact in those employees and in patients across the globe. But back to what I wanted to talk to you about was, when you're in front of Congress, you're defending the work that we're doing. You're defending how we're interpreting legislation, whether or not we're able to do it. And for those of you who watched the PACT Act hearing that was conducted a few months ago, and the two witnesses were the Undersecretary for Health, Dr. Elma Hall, and the Undersecretary for Benefits, Mr. Josh Jacobs. Those two were able to talk about the work that you're doing and to demonstrate how that has made an impact. It's been the largest piece of legislation that we have implemented in this country, that I want to say in the last 50 years, and it's going to make huge impacts for years to come. So just wanted to tell you that what you're doing does have a direct link to everything that you're seeing on the Hill. I wanted to also share with you some perspectives, because I know there are a lot of things that are coming out of headquarters that are tough to deal with. And I think probably the number one item that is probably the most controversial is the bookability policy. I see some smiles, maybe a few nods, but we know that in primary care, for the most part, when you are supposed to be seeing patients, you're booked when you're seeing patients. I just wanted to make sure that people understood that bookability does not mean that we expect your panels to always be booked, because we know that that will make it harder for patients to get in for an urgent or emergent visit to see you. Actually, I shouldn't say emergent, because I shouldn't be coming to see you, it's emergency. But we want you to have the ability to be able to see patients during that time. So if you have a 36-hour work week where you're seeing patients and a 4-hour work week where you're doing administration, you're probably a little bit more aggressive than some other folks. We want to make sure that 80% of your time is spent providing patient care. And again, it's going to look different ways for different specialties. It's going to look different ways for different areas of focus. If you are available to be seeing patients that may not be on your panel, if that's the way your clinic is operating, that still counts towards your bookability. We just want to make sure you have time to do administrative work. And although Dr. Elma Hall has told me, don't tell them this, but back when I was in practice, we didn't have the protections of having essentially 20% of our time for administrative time. So we hope that you're able to do what you need to do in that 20% that's remaining. We know that there's probably still some charting, still some contacts, still some reviews of studies that you may be doing after hours, but we want to make sure that you have the opportunity to be as impactful during the time that you are available and during the time that you're not available, that you're doing those other things. And one other point I want to make about bookability is that if you are doing something else, such as teaching, that is not part of the bookability portion of your primary care work. So again, we're talking about the time that you're in the clinic, whether you're teaching the students in the clinic or the residents in the clinic, or you are seeing patients directly one-on-one. We're looking at that time. So I would love to hear if there are any questions or concerns about interpretations about bookability before I move on. Maybe it's not this group that's having.
There's one.
Okay, I'm sorry. You stand up and I know we don't have a mic, but
we do.
Okay, perfect. We're going to pass it on. If you wouldn't mind, will you say your name for my benefit and where you're from?
Hey, I'm John Charvis from Palo Alto VA Primary Care. Yeah, I think with the bookability, I know we've talked about it a lot. I understand too, back in the days we didn't have admin time, been there. But it just feels to me like it's the elephant in the room, where there's plenty of evidence that the amount of time it takes to do that desktop medicine far exceeds the 20%. And so it does feel to me like, on the leadership side when I'm there, I'm like, yep, I've got your back, and we're going to tell them that. But on the frontline side, it just feels to me like it's the emperor has no clothes, right? I just can't convince my frontline providers who are all consistently working after hours to keep up. There are a lot of green screens, and there are a lot of good work underway to help. And so I don't want to discount that either, but it feels to me like it's a little bit difficult to kind of communicate out that 20% should be doable, because I think it's really at least one standard deviation, if not two standard deviations out of the norm for people that can keep up with that.
Okay, thank you for that comment. You said Charnas?
I tell my patients it sounds like Cheetos, but it's Chardos.
Charnas, okay, perfect, sorry about that. So thank you for that. We are definitely hearing that. What we would like to do is continue to hear from you all. We know that it's still a challenge for many people. As you heard Dr. Clancy talk about a little bit yesterday, there are some innovations that are being looked at. She leads some learn, and often we get things being proposed through the simulation learning environment that come in. And so the proposal to have the software running in the background while you're having a conversation with a patient is something that is being closely looked at so that we can take some of that burden off of you. We know that only 5 facilities are working right now under the new Cerner Oracle, and the rest of you are still working in CPRS. So we're also looking at how we can bridge that gap. And then there are other modalities that we're looking at to augment what we're doing. One of the things I mentioned when we first started implementing PACT was why couldn't the screening be done outside of a face-to-face contact or direct-to-patient contact? Why couldn't the patients fill out the questionnaire? And unfortunately, we went back to Congress and said, this is something we think our veterans can fill out themselves, or at least start themselves. And it was not something that was considered and not something that would be allowed. So we hear you, and we know that some things are not as optimal as possible. But the reason why we're trying to shoot for the 80-20 is because of the fact that we, by our estimations, by our data that Dr. Dina Tulsa's office gets, we have an inefficiency of just under about 500,000 slots. And so if we can hopefully demonstrate that we can bring our patients in and see them timely and get them in, then we can hopefully make the case for not moving further along this kind of paradigm of how can we increase access. So the other piece of this that I should have mentioned, I know there's another hand in the room, is that in addition to bookability, there's the see the patients as soon as best care, there's hiring initiatives, all those things are designed to make sure that we're able to take care of this work that needs to be done and able to take care of our veterans. But we still have, we've not demonstrated a lot of return on the investment of the new hires. And so we need to make sure that we're as efficient as possible before we continue, unfortunately, to bleed our patients into the private sector. Not so much so in the primary care, but I've also told Dr. Hall that if we continue to squeeze primary care, they won't have the ability, our clinicians won't have the ability to think about the patients in front of them, and therefore they're going to make referrals for specialty care, which is more expensive, more often. So that has not gone unspoken or unnoticed and is part of the equation of all of this. So we hear you. We're trying to make the case for showing that we are being as efficient as possible before there are questions about other solutions. And some of you can go and guess what some of those other solutions are for getting more patients in. So I don't want to say anything that hasn't been set in stone or anything, but we're trying to make sure that we are doing everything possible to demonstrate that we are able to take care of our patient load. And again, we do have about just under, if you look at, if we optimize all of our PAC teamlets, if we optimize our hiring and our ability to see patients, then we should be able to accommodate just under 1 million more patients. And right now with our inefficiencies, we probably have some opportunities for about 500,000. So that's where this is coming from. So I hear you, and I will continue to raise that. So don't feel as if you said something that's not going to go back. It's going to go straight to Dr. Hall next week when we're going to meet him. I saw one other, I thought there was another hand. I'm trying to be cognizant of the time. Yes.
Hi, Dr. Scavella. I'm Pretty Bath from Visit 22. We do look at our bookability in Visit 22. I'm proud to report that clinical resource hub anyway, we are 80-20. But I wanted to ask you for your advice on how to balance the burnout that the physicians are reporting. So when the AES scores come back, burnout has been going up. So how do we balance the two and get the right message to the doctors?
Yeah, that's a great question. Thank you for that question. So yeah, we know that burnout is a concern, and Dr. Upton has mostly been leading that charge at central office to try to make sure we have tools in place. And I have heard directly from clinicians in the field that they feel as if it's just kind of talk headquarters, but it's not actually being actualized in the field. I know you have lots of demands on your time. I know you have the inability to always step away the way that you need to. And as Dr. Truss asked me earlier, do I have any hobbies other than, what I do for work? I hope that each of you has something that you enjoy doing that's your outlet. And that the things you enjoy doing, you're able to find time to do. And that you can, in a bit, compartmentalize when you're at work and when you're doing the work you need to do, that you're able to do it. But then when you're not at work, hopefully you're enjoying the heck out of your lives and your families and your friends, and you're not doing it. Even just having a few minutes just to do a few yoga moves, which, funny thing, I started doing that in 2 previous roles. We didn't have a lot of time either, but we found 15 minutes in the middle of the day during most of what time we would have had lunch if we had lunch. During that time, and we would just do a few yoga poses as a group, whoever had time, whoever could do it. And it's funny, just that little bit of stuff, that little bit of movement, that little bit of break from whatever we were doing made a difference. So I think you can be creative in finding what you can do in your groups when you're working, and even if you get just a few minutes just to step around. Like in headquarters, I can honestly tell you, I don't have lunch. I eat in between meetings. I eat when I turn my camera off if I happen to be on a Teams meeting. So we understand that that's not what we want you all doing. I walk though in the morning before I get to work because I take public transit, so I walk in the morning, I walk in the evening, and I get up every single morning no matter what I'm doing. I did it this morning. I always work out half an hour in the morning. I do it in the morning because that's the only protected time I have. And I think all of those things make a difference in how I feel as far as the ability to do my job. And who the Peloton players or runners or rowers. Okay. So honestly, that's what gets me pumped in the morning and gets me going and gets me ready to do what I need to do. So I just ask each of you to find what that passion is, find what that outlet is, and do it. And try to find the ability to be resilient when you're in face-to-face care. But we are definitely following burnout. I hope that the messages coming from Dr. Fligler's office are making it to your attention as far as the different things we're trying to do for burnout. But hope that you're finding ways to do some of those things, not everything, but some of those things to make sure that you are rebuilding yourselves, essentially making yourselves able to do the work that you're doing. That was a great question. There you are. You were over there. You're welcome. So I know we have just about 10 minutes left. I did want to do a few recognitions.
We have time for one more?
Yes, we have another question.
Cynthia Hines with the Albuquerque VA New Mexico. Just a quick question on panel size. I know that there's a correction factor for women's health for the general PAC, and that there at one time was a correction for the CAN score until we realized there were some questions about the actual workload. Why isn't there a correction factor for opiate patients or for patients that would normally go to geriatrics, but because we don't have enough geriatricians, it's taken care of?
That is a great question, so thank you for asking that, and thank you for your service, because I know you're one of the people who stood up. I think that one of the good things about this organization is that we listen to our folks in the field, and so if that is a carve-out that we haven't considered, that's something we can look into. And I know that patients who are on chronic opiates, while we're trying to reduce dosages and frequencies and things like that, they do take a little bit longer because you've got to do a lot of administrative things. But I think we can probably make that argument for many different specialties, many different areas like diabetes. So we may have to look at that. We've been very, I would say, regimented in looking at things based on panel size and PAC team with composition. And whether you have 2 rooms and then there's a flex room, or whether you truly are working out of 1 room and you're in a small clinic where you may be 1 or 2 clinicians. So I know that those are the factors that we do look into. But as you identify other things that you feel as if the timing is not appropriate, please let us know so we can take a look at that and look at the statistics behind it. So thank you for listening to that. So I did want to do, I always try to make sure that as I am moving doing across the country and meeting with groups, I get an opportunity to recognize people who have truly made an impact in what we are doing. So I would love Drs. Hunt and Vargo, as well as Dr. Matras, Dr. Carter, Dr. Diatolis, and Ms. Law to come to the stage. So I want to recognize Dr. Diatolis and Dr. Matras for their leadership for PACT. For all the work they've done with PACT, there has been a huge heavy lift that has taken place to get this into position. So I just want to thank them. I want to thank Ms. Heather Ball for being the force behind trying to wrangle all of the senior executives to get us here, which is a huge feat, and I know that you're continuing to do that, so I will not re-recognize you, but I know that you're planning multiple meetings, and I really want to thank you for that. For Dr. Vargo and Dr. Hunt, I just want to thank you for always representing VA primary care at the American College of Physicians, which takes place annually. They always give a talk, and they talk about the perspective of what you should be doing if you're not a VA physician and you're seeing patients. And so their speeches have been very impactful for bringing awareness to what we need to do across the country. And this year, my husband actually went into one of your sessions and came back and talked to me about your session because he's a chiropractic physician. And then for Dr. Carter, she has been leading many efforts to improve everything that we're doing in primary care and to bring a voice to central office that represents your voices, which is not always an easy feat. First of all, to get her voice noticed and to bring in the concerns and perspectives of you. So the things that I've heard through her, through Dr. Diatolis, and with last but not least, Dr. Palakowski. He has been instrumental in bridging many roles in primary care. He's been working with the CMOs closely and has stepped into primary care more completely. But his ability to, again, bring the voice of primary care forward has been really impactful. So I just wanted to recognize them, and I also wanted to give him one of my points. And I want to take a picture, and then we'll put you back here. Everybody can take it, yes. Okay, perfect. This is not the way it's supposed to work.
There's a phone up here, Dr. Scavella.
Oh yeah, no, I'm not looking for the phone, I'm looking for 2 more coins.
In the meantime, guys.
In the meantime, you can give it back.
Yes. Dr. Matras, Dr. D.
Smile.
Thank you.
So with that, sorry about that. So with that, I just wanted to thank each of you for everything that you're continuing to do. I look forward to engaging with this group, going across the country at future meetings. I think I can actually make at least 2 of the ones coming up. And I appreciate everything you're doing, and I'm going to make sure that Dr. Elmhall knows about the engagement, about the topics you've discussed, and again, continued concerns about bookability and also panel sizes.